Hello everyone, I'm Dr. Sandeep Sharma. So the INI CET exam is done. So we have some recall questions here. Let us do the pediatric pattern recall questions in November 23 exam. The paper pattern was dramatically different. There were 4 blocks this year, but the overall weightage, the quality of questions, the topic repeats were very similar to the previous years. First, the disclaimer, it is based upon the recall by the students. So obviously, if there is any change in the way questions have been framed, so obviously the answer will also change. So it is the topic and the way questions have been framed, which is more important for those who will be targeting the subsequent exams after this. And any resemblance to actual MCQ is incidental. So let us start with the questions. So the question number 1, which was asked in INI CET November exam, a very similar question was asked. Which of the following is not seen in a child with Down syndrome? Now, there are 4 options which are given. So what do the textbooks say? OP Guide textbook, the new edition which came this year, 10th edition, it very clearly mentions that linear growth is retarded. In other words, short stature is present in a Down syndrome child. Secondly, about 13 to 34% patients with Down syndrome have hypothyroidism. So up to 1/3 patients are going to have uh, low thyroid function and they are going to require thyroxine supplementation. So short stature is also present, hypothyroidism is also present. So we are left with option number A and D. Third option, 40 to 60% patients are found to have conductive hearing loss and are prone to develop serious otitis media, particularly in the first year of life, in the infancy period of Down syndrome. So conductive hearing loss is also found. What are we left with? Caudal regression syndrome. Caudal regression syndrome is rare in general population. It is rare in other syndromes, but it is a relatively frequent finding in children who are born to diabetic mothers. So caudal regression syndrome is a malformation specifically seen in infants of diabetic mother, right? Now, some people are of the opinion that there was also an option mentioned as cognitive impairment which was present. So, cognitive impairment is also seen in Down syndrome. Cognitive impairment is nothing but low IQ, developmental delay. We all know that Down syndrome children are going to have those. So, congenital heart diseases, duodenal atrecias, cognitive impairment, short stature, hypothyroidism, they all are present in Down syndrome. What is not seen or what is least likely seen? It is caudal regression syndrome, it is least likely seen. Because caudal regression syndrome has been asked in other competitive exams in the past also. So let's do a small quick review, which is going to be beneficial for your future exams as well. So caudal regression syndrome is also called as sacral agenesis. Variable degrees of bilateral lower limb deformities will be there and it will be associated with genitourinary malformations. It is rare in general population, but as I said, it is more commonly seen in infants of diabetic mother. It is considered to be specific for these babies. So it is a specific malformation in infant of diabetic mother. Now, the degree of caudal regression syndrome, it's not a single condition. You need to understand that there is a spectrum. I will show you 3 images and all the 3 are caudal regression syndrome. So look at the first image. In this variety of caudal regression, you will find that the lower limbs are hypoplastic, they are having contractures, and it is associated with the genitourinary malformation as well. This is one variety of caudal regression. Second variety of caudal regression will be a severe form where the lower limbs will be fusing with one another, right? So it will produce the so-called mermaid appearance. Now, mermaid appearance can also be seen in another condition called a sirenomelia. So Sirenomelia is true mermaid appearance, but similar appearance can also be seen in caudal regression syndrome, right? So the two limbs will be fusing together. So this is also one variety of caudal regression syndrome. And the third variety is where the lower limbs are not formed at all or they are severely hypoplastic. Look at this person. This is an actual person. He's a motivational speaker. He's a Paralympic athlete and he's a quite popular man in the Western Hemisphere. His name is Zane Clark. Zane Clark is a person who was born with caudal regression syndrome, and as you can see, he's not having any lower limbs at all. They are severely hypoplastic. I would say they are absent. But this person did not give up. Uh, he worked hard. He's a bodybuilder. He's a Paralympic basketball player. He's a Paralympic athlete. And he has been motivating a lot of people saying that if I can do without 2 limbs, why can't others? So he's a motivational speaker as well. So these are the 3 varieties of caudal regression syndrome. So it is not just one picture, but you need to understand that these are the three broad varieties into which caudal regression syndrome, any of these similar images can be asked to you in the future exam. Caudal regression syndrome, specific feature, infant of diabetic mother, past MCQ point. You can just remember it as a past one-liner, right? Let's move further. Let's talk about question number 2. A baby has received BCG at birth and has been vaccinated at 14 weeks. Which of the following shall be given on the next visit along with the route and site? Now, the next visit after 14 weeks will be coming at what age? It will be coming at 9 to 12 months of age, right? So according to National Immunization Schedule, the next visit will be after 14 weeks, it will be 9 to 12 months. And when we say 9 months, it is 9 completed months that you should be giving. So 9 to 12 months, what all you will be giving? You will be giving MR vaccine, first dose. You will be giving oral vitamin A to the patient. In case of endemic areas, you will be giving Japanese encephalitis. And according to the latest update in National Immunization Schedule, now you will be giving fractional IPV third dose also to the patient. So these are the vaccines which are going to be given at 9 to 12 months. Now the question here was interested in knowing when will you be giving them and at what site? MR vaccine by convention is always given in the right arm. Why right arm? Because left arm you give Japanese encephalitis vaccine in case of endemic areas. So look at what National Immunization Schedule says. So MR first dose, 9 completed months, it is very clearly mentioning. The catch-up vaccination can be given up to 5 years of age. If someone misses it, you can give MR vaccine up to 5 years of age. 0.5 ml is the dose. You reconstitute it with sterile water. It is given subcutaneously, and upper right arm is the site where it is given, right? And about oral vitamin A, you give at 9 completed months, and 1 lakh international unit is the dose. It is given orally. So what is the correct option here? MR vaccine subcutaneously on right arm and oral vitamin A at 9 months completed, right? Now, we are not sure, I'm not sure that whether Japanese encephalitis and fractional IPV were mentioned in the question or not. But this, based upon what students have shared with me, similar options were there. And this option number B, according to the options, appears to be the correct answer. What was the actual question that you have to figure out for those who have given the exam? Now, question number 3. Question number 3, 2 versions were shared with me by the students. So both versions I'm going to take up and I'm going to tell you the explanation so you can figure out what is the likely answer. First version says a mother brings her 9-month-old child to the hospital. So look at the age 9 months. The child is having a respiratory rate of 48 per minute, no chest retractions or other signs. Some people said, sir, SpO2 was also mentioned, which was normal. It was 98 or 99%, right? So what is the next step in management? This is asking about WHO IMCI or IMNCI guidelines of pneumonia. We need to first of all see whether there is tachypnea there or not. Age less than 2 months, tachypnea is respiratory rate equal to or more than 60 per minute. Age 2 to 12 month, respiratory rate is equal to more than 50 per minute. And 1 to 5 years, respiratory rate equal to more than 40 per minute is taken to be tachypnea. So this is the cutoff to define tachypnea in the child. Now, if you compare with the age given, 9-month child, the respiratory rate should be more than 50. Here it is less than 50. So there is no tachypnea, there is no chest retraction. So basically, the child is having a upper respiratory kind of infection, even if there is some fever or cough or any other thing mentioned. So what is the next step in management? No treatment is needed. One of the students said, sir, the option was no treatment, bracket they had mentioned symptomatic management. So what you will be doing here is symptomatic management alone, because this is not pneumonia. So answer to this question, this version, if this was the question, the answer is no treatment is needed, right? Because there is no tachypnea, there is no chest retraction. Why would you call it as pneumonia? There is no danger sign, right? This is the first version. Look at the second version, what people said. The second version was mother brings her 9-month child to the hospital. Child is having tachypnea, but no chest retraction or other sign. You diagnose the child as pneumonia. They had mentioned it as pneumonia. This is what some of the students said. Now, this is based upon recall, right? Recalls, these things happen. So I am putting it out, both the versions for you. You have to see what it was asked. More than what version was asked, what is important is how you're going to make the diagnosis. That I will be coming in some time. So what is the next step in management? So when you diagnose a child as pneumonia, right, either tachypnea or chest indrawing, but not danger sign, we call it as pneumonia according to the latest IMNCI. In pneumonia, you start oral amoxicillin, oral antibiotic, and send back the child home and review the child in 48 hours. So in this version, if they mention it is pneumonia and if they mention there is tachypnea, you will be starting oral antibiotics and sending the child at home and review after 48 hours. Now, what do we need to remember? Whatever is the version 1 or 2, it doesn't matter. Exam is done. For NEET PG, for future INI CET, have a look at pneumonia diagnosis and management. What I'm going to show you is the IMNCI latest update. Many of you have been reading the older updates. Please discard them. Please throw them away. This is the latest update. Subtle change. I will be highlighting it. So if there is no sign of pneumonia or very severe disease, we say child is having pneumonia. When do you say pneumonia? If there is either fast breathing, that is tachypnea, the cutoff I have just told you, or chest indrawing. Earlier, according to IMNCI, chest indrawing would indicate severe pneumonia. Now it is very clear, it is either fast breathing or chest indrawing. In a child with fever or respiratory symptom, if they are present, in a age 2 months to 5 years, we call it as pneumonia. And what do you do in pneumonia? Give amoxicillin for 5 days and you follow up the patient after 2 days. So every child started on amoxicillin needs to be reviewed after 48 hours. The dose of amoxicillin is 80 mg per kg per day, given in 2 divided doses. And in case the child is having any general danger sign, or there is stridor in a calm child, or SpO2 is below 90%, we call it as severe pneumonia. Severe pneumonia is also called as very severe disease. You will give ampicillin and gentamicin, and if you are sitting in a primary health center, you will refer urgently to hospital, and on the way, because hypoxemia will be there, you will provide oxygen, supplemental oxygen through face mask or nasal prong, whatever is possible to these children. If you compare it with the older guidelines, there are small subtle changes in how you define pneumonia and what are the steps you are taking. So please take a screenshot of this video which I'm discussing and update your existing notes for the future exam. Every alternate year, NEET PG and INI CET, there is a question on diagnosis of pneumonia in a child. So this is the latest update, IMNCI update, that you need to remember. So based upon whatever options were given to you, remember this table and you will get your correct answer. Question number 4. Which of the following is an effective indicator of perinatal asphyxia? Perinatal asphyxia, previously called as birth asphyxia, it's a common problem which occurs when a child born does not cry immediately at birth and resuscitation is delayed. So there is interruption of oxygen supply to the brain and the various organ tissues. The clinical state arising because of that is called as perinatal asphyxia. Now, for perinatal asphyxia, there are specific tables, guidelines which have been given, and there is in OPIG 10th edition, there is a table given. The table talks about essential criteria for perinatal asphyxia. What are the essential criteria? Look at the options one by one. First of all, any child where you are suspecting asphyxia, as soon as birth is happening and you are doing resuscitation, one of your assistant will take out some blood from the umbilical artery and send it to ABG lab. When the blood report comes later on and you find that the pH in the umbilical artery blood is less than 7, that will indicate acidemia or acidosis. It can be metabolic or it can be mixed acidosis. So pH less than 7 in umbilical artery blood is one of the criteria for asphyxia. Second, if low APGAR score, I hope you know the interpretation of APGAR score. 7 and above is normal, 4 to 7 or 4 to 6 is moderately depressed, and 0 to 3 is severely depressed. So if there is severely depressed APGAR score for more than 5 minutes, that is also criteria. In case there is any neurological manifestation like seizures, coma, hypoxic ischemic encephalopathy, or hypotonia in the patient, I have highlighted this. That is also a essential criteria, and any multi-organ dysfunction apart from CNS in the immediate immediate neonatal period after resuscitation is done, that is also suggestive of perinatal asphyxia, right? So these are the 4 criteria. Ideally, all 4 should be present to diagnose it. If not possible, the maximum you can find, the better, the more certain you are that it is perinatal asphyxia in a newborn child. Now, what is the question saying? Which of the following is an effective indicator of perinatal asphyxia? Look at options one by one. Cord pH less than 7.2 is not the answer. Cord pH should be less than 7.0. Hypocalcemia can occur in asphyxia, but hypocalcemia is not a marker of asphyxia. Hypocalcemia can occur due to other conditions also, and hypocalcemia can sometimes be a benign, innocuous, incidental finding as well. So it is not a marker. APGAR score 4 to 7 beyond 5 minutes, 0 to 3 beyond 5 minutes. What are we left with? Hypotonia, flaccid baby, loss of tone. It is one of the manifestations It indicates CNS involvement, neuronal involvement in HIE, and that is the correct answer. So question number 4, the answer is D, hypotonia. Question number 5. Now, I'm not sure whether it was an adult patient or it was a child, but sickle cell anemia, there was a question. So that is why I have included it here, right? In sickle cell anemia, which drug is used to decrease the incidence of painful vaso-occlusive crisis? Now, you need to understand one thing. In sickle cell anemia, there is HBS, which is there. And the sickle-shaped RBCs which are produced, they have a tendency to stick to each other, producing polymerization. So normally what will happen is, suppose I am a patient with sickle cell anemia and I undergo hypoxia, or I go to a high altitude, or there is illness in me. Because of acidosis or hypoxia, what will happen is the RBCs will become sticky in sickle cell anemia. They will stick to each other, forming long chains or polymers. These polymers will block the small blood vessels, and small blood vessels will, when they get blocked, it will produce ischemia of the organs. It will cause ischemia and painful episodes in the long bones. It will involve hands and feet involvement. So dactylitis, the so-called hand-foot syndrome, can happen. Male children can develop priapism, stroke, MI, renal vein thrombosis, renal papillary necrosis. They all have been described. That painful condition is called as painful vaso-occlusive crisis, right? Now, what are the drugs which can reduce it? There are 3 drugs which are approved for decreasing the chances of painful vaso-occlusive crisis. Traditionally, the most commonly used drug in these patients is hydroxyurea. How does hydroxyurea help? Hydroxyurea helps by increasing the levels of fetal hemoglobin. It increases HbF, and we know that fetal hemoglobin interferes with sickling of the RBCs, and so it reduces the chances of vaso-occlusive crisis. Then there are new drugs which have been approved for use to decrease the vaso-occlusive crisis. These new drugs are FDA approved, and these new drugs are potential MCQ points also. They have been added in OPGAI. So make sure that all the important updates you are thorough with. So 2 new drugs are available to decrease vaso-occlusive crisis apart from hydroxyurea. One is called as voxelotor, and second is a monoclonal antibody called as crizanlizumab. Both voxelotor and crizanlizumab decrease chances of RBC polymerization, and so they reduce the incidence, the chances of developing a painful vaso-occlusive crisis. If you look at the 4 option, which is the option which has been introduced here? It is hydroxyurea, and that is the correct answer. So new drug based question. Question number 6. Which of the following is true regarding congenital CMV? Right? Look at the options. Option number 1 is saying CMV is a common intrauterine infection second to syphilis. Syphilis is common, but it is not that common. Which is the most common congenital infection? I've been teaching, we all have been teaching, all the pediatricians have been teaching that congenital CMV is a hugely important topic, and it is one of the most common congenital infection if you look at all the other organisms. So A option is not true. A option is a false statement. It is a false statement. Why? Because it is not second to syphilis. It is the most common itself. So what I will be giving references also. So Cluharty textbook and Nelson textbook of pediatrics, both of them agree that congenital CMV infection is the most common congenital infection and a leading cause of birth defects and pediatric disabilities. This is what one of the textbooks says. So option 1A is false. Option B. Blood PCR is best for diagnosis within 2 to 3 weeks of birth. Yes, within 2 to 3 weeks, you should make the diagnosis. But blood is not a good sample for doing PCR. It is saliva and urine which are good samples. It is also a past AIMS MCQ itself, 2018 or 19, I think. So where they had asked what is the best sample for doing PCR. It is the saliva followed by urine. Blood PCR has poor sensitivity and specificity. You can use it, but the better options are now available, and all the commercial PCRs which are available, they utilize only saliva and urine. So option B is not likely to be true. So sensitivity and specificity of using this PCR, this is what the textbooks is saying. It is quite high for urine and saliva, but a negative PCR in blood does not rule out infection. So blood is not a good sample for doing PCR in these patients. Saliva is a preferred specimen in infants due to the ease of collection, and it has good sensitivity and specificity as well. So option number B is going to be false, right? Option number C, asymptomatic patients with congenital CMV have risk of SNHL. It is actually a true statement. OP Ghai 10th edition says, babies who are asymptomatic at birth can manifest later with sensorineural deafness. Sensorineural hearing loss is the most common sequela of congenital CMV. It is majorly seen in symptomatic CMV, but can also occur in 5% patients of asymptomatic CMV, right? So asymptomatic patients can have risk of SNHL. And option number D, 30 to 40% are symptomatic at birth. That is wrong. 90% are found to be asymptomatic and 10% are found to be symptomatic. So only 10% are found to be symptomatic at birth. So this is also a false statement, right? So what they are asking about the true statement, what is the true answer here? Option number C is the true answer. Obviously, if the statement, these are all statement based questions. And if the actual paper, the recall was different from this and the language was different, the options can also change. So it is important for me to put out the information here. Eventually, you have to see what actually was asked in the exam and how your answer was correct or incorrect in the actual paper. In fact, OP Ghai is also saying the same thing. If you see, OP Ghai is saying, look at this box here. It is saying the diagnosis of congenital CMV can be confirmed by a positive IgM, which we don't do these days anymore, or urine CMV PCR in the first 2 to 3 weeks. So, karna to 2 to 3 weeks mein hai, but it is urine or saliva PCR, not blood PCR, which is done, right? If they would have mentioned PCR to be done within 2 to 3 weeks, that would have been a correct option, right? Then some other option would have been incorrect. But here, blood PCR is not done. This is what the examiner was probably trying to ask. Now, we don't know what examiner actually put, because there was a lot of controversy regarding these options. I had to ask a lot of people about the exact question stem. For future aspirants, what you need to remember: key points regarding congenital CMV which have been asked in the exams. First is, in the West, primary CMV infection is more common during pregnancy, while in India and developing countries, it is the reactivation or reinfection. What is the meaning of this? There is a statement-based MCQ on this in the past INI CET paper. Understand, I am a pregnant woman. Imagine, I'm not, but imagine I'm a pregnant woman. Now I can get CMV infection in two scenarios. If I'm living in United States, Western world, if I get CMV in pregnancy, it will be the first time I'm getting. So primary infection will be more common in the Western countries. Whereas in Indian setting, by the time I get married and I get pregnant, there is a chance that I will have exposure to CMV already. CMV happened, it was asymptomatic, and I developed antibodies. So if I get pregnant in India and I get CMV in pregnancy, it is going to be reactivation or reinfection, right? So which is the more common in the Western world? Primary. In the Indian world, it is reactivation or reinfection, right? Any person who is having reinfection will be having IgG positivity, and so the chances of fetal transmission will be low. What are the percentages? Fetal transmission rate in primary CMV is 30%, and fetal transmission rate in reinfection or reactivation is 1%. There are MCQs on virtually all of them in one form or the other in the past 10-year papers, if you see, in Neet PG as well as INI CET. And 90% cases of congenital CMV are asymptomatic, 10% are found to be symptomatic. This is what one of the option was. Most common sequel of congenital CMV is SNHL. There is a past AIMS question also. Sensory neural hearing loss. What is the most common non-syndromic cause? The answer was CMV. So SNHL, sensory neural hearing loss, sensory neural deafness can occur in 60% symptomatic, 5% asymptomatic patients. Investigation of choice is PCR on saliva followed by urine. Culture, if you want to do, only urine is the best sample. Blood and CSF have low yield. And what is the drug of choice? IV ganciclovir for 6 weeks. If IV ganciclovir is not available or not tolerated, you can use oral val ganciclovir, but it needs to be given for 6 months. This slide is containing at least 7 to 8 past MCQs. And if you are targeting INI CET exam and you have missed out on any of these one-liners, please add them to your notes. I've taken some time explaining this topic. You can fast forward it later. It's a recorded video, obviously. But this slide is extremely important. Please add it somewhere in case you have forgotten any of this information. They're all past MCQs, past statements in various exams. Let's move further. Question number 7. A case on infant with breathing difficulty, high respiratory rate, and scaphoid abdomen is mentioned. whenever there is scaphoid abdomen means boat-shaped abdomen, you will be suspecting what condition in the patient? You will suspect CDH. CDH stands for congenital diaphragmatic hernia. So this is a patient who's having a congenital diaphragmatic hernia. What should be avoided in the patient? We all know bag and mask ventilation is absolutely contraindicated. Why? See, what is diaphragmatic hernia? There is a gap in the diaphragm. So intestines are herniating into the thorax, right? Now, if you give bag and mask, you push the air, some air will going into the lungs, some air will be going from the mouth into the abdominal cavity, and all the air going into the stomach will increase the intra-abdominal pressure, worsening the diaphragmatic hernia, right? So patient can worsen on bag and mask ventilation, and that is why it is contraindicated where you are suspecting diaphragmatic hernia. Textbooks also say all infants with known diaphragmatic hernia should be intubated immediately after diagnosis. Bag and mask ventilation is contraindicated in the patient, right? So question number 7, it was an easy one. Question number 8, which congenital infection is least teratogenic to the fetus or newborn? CMV is teratogenic, we know. Rubella is teratogenic, we know. It is one of the most teratogenic infection. Rubella syndrome is produced. Chicken pox can also produce cicatricial skin rash and limb hypoplasia. HSV2 is the one which is likely answer. Textbooks also say in utero infection with HSV has been documented, but it is uncommon. Very rarely it can cause some degree of chorioretinitis or hydrancephaly, but vast majority of HSV2 is considered to be a intrapartum or a peripartum infection. It is transmitted during childbirth. It is not transferred commonly in utero. And even if it does get transferred in utero, various review articles mention the rate of teratogenicity being around 1% or less in case of HSV. And 1% or less is negligible. So among these 4, which is least teratogenic, it is HSV2 which is least teratogenic. Question number 9. Which among the following is or are true regarding sweat and pancreatic chloride levels in cystic fibrosis? So you know what is cystic fibrosis? It's a multi-system disorder. CFTR gene mutation happens. Epithelial chloride channel is deficient. And because of that, abnormalities happen. Now, what do you need to remember? Let me give it as a summarized form. In respiratory tract, pancreatic duct and the GIT, in the gut, the normal function of CFTR is to secrete chloride. When chloride is secreted, sodium comes. When sodium chloride comes, water comes. So its aim is to promote hydration of secretion. What will happen in case there is cystic fibrosis? CFTR will not be there, and so chloride levels in secretions will decrease. This will lead to thick mucus, thick secretions which are unable to move, which are unable to be cleared. And that is the pathophysiology. That is why recurrent pneumonias happen. That is why malabsorption happens. And that is why back pressure changes leading to pancreatic damage happens in these patients. And newborns can develop meconium ileus as well. So chloride secretion in chloride concentration in pancreatic secretions will be decreased. Option number D is correct. Look at the second part. In sweat glands, the function of CFTR is opposite. It is to absorb and preserve chloride. So if CFTR is not there, absorption will not happen. So there will be excess loss of chloride in the sweat. So sodium chloride loss in the sweat will lead to excess dehydration chances in the patient. And this loss of excess chloride in the sweat is responsible for the so-called positive sweat chloride test, which is a screening test for cystic fibrosis. This is also a past Neet PG as well as INI CET MCQ. So chloride excretion is increased in sweat. So chloride excretion is decreased in pancreatic secretion. Chloride concentration is increased in sweat or sweat gland ducts. So option number A and option number D are correct. Now, next is the overlap or likely question number 10. Now, we don't know whether age was mentioned here or not and whether it was adult or a child. The question was a vegetarian or a vegan patient who has a high MCV, more than 100, and HB of 10 gram percentage, suggestive of some mild anemia. So, whenever you have a macrocytic anemia, this is what you call as macrocytic anemia. So, and this is suggestive of anemia. So, which among the 4 options, which is the variety in which macrocytic anemia is seen? It is megaloblastic anemia, and that is the likely answer. If additional information was given, that would obviously change the answer, but similar question was given to me by the students. Question number 11, match the column question, is an easy one. What is the disease and the corresponding mode of inheritance they had asked? So, On one side, you have the modes of inheritance, other side, we have diseases. We know that cystic fibrosis is considered to be a autosomal recessive condition. Leber's disease, also called as Leber's hereditary optic neuropathy or LHON, is considered to be a mitochondrial disorder. Myotonic dystrophy, also called as dystrophia myotonica, it shows autosomal dominant inheritance. Myotonic dystrophy is a distal muscular dystrophy. This is a condition which is also categorized as a trinucleotide repeat disorder, right? But type of inheritance shown is autosomal dominant. And fourth is X-linked recessive. We know Duchenne's muscular dystrophy is X-linked recessive, and only boys are affected with Duchenne muscular dystrophy. So the correct sequence will be A3, B1, C4, and D2. This is the correct answer, right? Easy one. Question number 12, which is a repeat question. Similar question has already been asked. 18-month-old child with 3 days history of watery diarrhea, vomiting, and altered sensorium presents to a hospital. Which of the following can be the differential diagnosis? So this child is having a watery diarrhea, right? Watery diarrhea. So diarrhea, vomiting, and altered sensorium, CNS involvement is present. So watery diarrhea and vomiting can lead to both hyponatremia and hypernatremia, and both of them can lead to altered sensorium in the child. So hyponatremia can produce such a picture, right? What about HUS? HUS stands for hemolytic uremic syndrome. HUS is characterized by a triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal dysfunction. None of them is mentioned in the question, right? None of them is mentioned. And HUS is often triggered by a dysentery-like illness. Here it is a watery diarrhea. So HUS is unlikely to be a differential diagnosis here. Severe dehydration can have altered sensorium. Their children are unable to drink, so that can be a possibility. Cerebral vein thrombosis can be a sequela, particularly in young infants, of severe dehydration. There can be thrombus formation due to severe dehydration, and that can cause altered sensorium and seizures in the child. So this will definitely be a possibility. So which of the following are the differential diagnosis? A, C, and D are the differential diagnosis. Now, some of the students were of the opinion that, sir, they had asked which of the following are differential diagnosis except. So if the word except was there, the answer would be HUS. But if the option was which of the following can be differential diagnosis, then you have 3 answers here: hyponatremia, severe dehydration, and cerebral vein thrombosis. So it will all come down to how the question has been framed, right? Question number 13. 3-year-old child is on ventilation with nasal cannula delivering oxygen at 3 liters per minute. What shall be the FiO2? So nasal cannula is in the form of nasal prong. We attach the nasal prongs in the nostrils of the child and turn on the oxygen. It is an alternative to mask, and it is slightly more efficient than delivering oxygen to the baby. This is a photograph of a child who is receiving nasal cannula oxygen. And what does Nelson say? Nelson 21st edition very clearly mentions, and it also gives the formula to you. It says that oxygen is humidified in a bubble humidifier and delivered via nasal prongs inserted into the nares, as you can see. In children, a flow rate of less than 5 liters per minute is most often used because high flow rate can cause irritation in the nostril. Common formula to estimate kitna FiO2 is being given to the child is as follows. So this is the formula given in Nelson. Nelson says FiO2 is 21% plus nasal cannula flow rate multiplied by 3. Now let us apply here. FiO2, what is, so the formula will be 21% plus how much is the cannula flow rate given here? 3 liter. So 3 multiplied by 3. So 21% plus 9, that will be 30%, and that is your answer. This question is very similar to one of the pre-test question asked in the older editions of Nelson. So examiner probably had this equation in their mind. This is a topic which can be considered in anesthesia. This is a topic which can be considered in pediatrics. In pediatric critical care, we commonly calculate these FiO2 ratios according to the guidelines. And if you are working in a pediatric critical care setting, this is a very commonly used formula, right? So we use it on a day-to-day basis. Anesthesiologists also use it on a day-to-day basis. So this is an overlap topic. It can be considered in pediatrics. It can be considered in anesthesia. So my duty is to give you the correct answer, because actual paper, they don't distinguish what is pediatrics and what is other subject, right? So question number 13. Question number 14, exact question could not be recalled. There was a question on meningitis. There were also meningeal signs present in the question, and CSF was showing low glucose, raised cells, and lymphocytes were present along with high protein. The answer was tubercular meningitis, because tubercular meningitis will have low CSF glucose, raised cell. The type of cells will be lymphocytic predominance, and the amount of CSF protein. CSF protein can be elevated in pyogenic also, but tubercular has higher elevation of levels in the patient. And tubercular meningitis also shows pellicle or cobweb coagulum formation. Now, I don't know what information was given, but based upon what this information was there, the likely answer will be tubercular meningitis. Obviously, if the information changes or specific values are there, the option will be changing. So, for future aspirant, that table which you remember, which has various CSF values mentioned, pyogenic, viral meningitis, tubercular meningitis, that table you have to mug up. It is there in your notes, but don't miss it before the future exams that you will be sitting for. So these were the questions which I could get hold of. There will be some more questions. You are most welcome to discuss with me. As I said, the discussion is based upon the recall. If the actual question was different or some other information was given, the answer will change. My purpose is not to tell you the answer key. My purpose is to tell you this is how the questions were asked, this is how you should be answering, and if a similar question is asked, what should be your approach. And some of the topics like congenital CMV, I have gone into detail because they have a high likelihood of being repeated again in the NEET PG as well as in the INI CET exam, right? So papers are overlapping, and many of these questions can be a part of the other subjects as well. So it has elements of pediatrics as well as other subject as well. I hope all of you will benefit from this discussion. Keep learning, and God bless everyone. All the best for the results. Thank you.